Hello, everyone. Okay, so I think it's 10:04, so I think we can get started here. Thank you, everyone, for coming. Welcome to Lessons Learned from COVID-19, a teaching moment in global surgical education. Thank you for coming on a lot of you guys' Saturday mornings. So first, I just want to say I am Grace, and I'm joined today by Albors, and we are second-year U of T medical students who are co-leads for U of T's first global surgery conference geared towards medical students like yourselves. So we'd like to also introduce our team. We're supported by a team of communication leads who are with us today, Sean, Nicola, Alexander, and Abrar. And they are also medical students from across Canada who are going to be helping to organize this conference, and you'll see them in your workshops, and they're going to be moderating them. So you'll get to meet them in a little more depth later on. So we have a ton of amazing speakers today and mentors as well, all of whom are leaders in global surgery. So just to give an overview of the talk today, we're going to be having our opening remarks, which will be given by Dr. Hodai, and then we'll have our keynote lecture. And basically, then we'll open up breakout rooms in which you'll be able to self-select a workshop of your choosing based on your interests. And this will run for both the morning and afternoon sessions. And then finally, last but not least, we'll have small group mentoring sessions at the end of the conference with individuals who are leaders in global surgery and had done a lot of global surgery work in their training and are willing to give mentorship regarding their path and their journey. So we're really excited to welcome everybody today. And that being said, before I hand it over to Albors, I'd first like to acknowledge that we've been supported by a lot of amazing partners in order to actually put on this conference. So first of all, we'd like to thank the International Office at the University of Toronto, because this conference was actually funded by what's called the U of T Student Engagement Initiative. And they support students who put on initiatives that promote global cooperation during COVID-19. And so we're very grateful for their support. We're also supported by the Greg Wilkins Barrick Chair at the University Health Network, Dr. Mojgan Hodai, who you'll be hearing from in a few minutes for opening remarks. And we're also supported by the University of Toronto's Department of Surgery, in particular, Dr. James Rutka, who has expressed his enthusiasm and support for this topic. You know that, I'm sure a lot of you know that he's done a lot of amazing work in global surgery. And so it's very meaningful for us to have his input and his support with regards to this conference. And lastly, we are partners with the Canadian Global Surgery Trainees Alliance, or CGSTA, which has shared goals with us with regards to promoting global surgical awareness amongst medical students and trainees.
So it is my great pleasure to introduce Dr. Mojgan Hodai, who has helped us over the past few months to put this conference together. And as a personal note, everyone who knows Dr. Hodai, they know that she's an amazing mentor, she's a caring supervisor, and we are very, very lucky to have her. Dr. Mojgan Hodai is a staff neurosurgeon at the Toronto Western Hospital University Health Network and holds the rank of professor in the Department of Surgery, University of Toronto, with expertise in stereotactic and functional neurosurgery. Dr. Hodai has a strong interest in neurosurgical education. She is the Greg Wilkins Barrick Chair in International Surgery at University Health Network, supporting the goal of advancing surgical capacity globally. In addition, she is the Postgraduate Medical Education Director of Surgery, as well as Deputy for Education for the Division of Neurosurgery at the University of Toronto. It's my great pleasure to welcome Dr. Hodai for opening remarks.
Thank you so much, Albors, Grace, and all the organizers. It's really wonderful to see all of you. Maybe we will start with a land acknowledgement as a measure of thanking the history of the Indigenous community in our land. So I will read this and hopefully you can read this with me as well. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home of many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So again, I want to thank the organizers, and really it is my pleasure to welcome all of you to this virtual conference in Toronto. It is also my pleasure to be able to help our team of medical students that have put together this conference. In my view, this is a unique conference organized by medical students for medical students, and the number of registrants and the number of participants really attest to the important interest that is building at the level of medical school in participation in global health and specifically global surgery. I'll speak from my own personal experience that really integrating the interest and the dedication to global surgery early in your career really pays off a lot later on. I did that as soon as I could when I was a resident. You guys are definitely ahead of me, and it's wonderful because it will form, I hope, a part of your career, and it will provide essentially an umbrella of your interests, whatever they might be, whether they're very broad aspects of surgical capacity worldwide, or even very subspecialized areas. The world needs surgeons, and surgical capacity has really taken a backseat, unfortunately. We need to change that strategy. At the same time, I think it's important to think of this conference as an opportunity to create new adventures, new opportunities for students within the Department of Surgery at the University of Toronto, and also outside. I hope that each of you that is not in Toronto really champions this cause at your own institutions, and together, nationally as well as internationally, we again increase the notoriety and the importance of this cause. We have a roster of amazing speakers, and I really look forward to listening to each of them. And in particular, I want to thank Graham Fieggen, who is joining us from Cape Town together with his team. Graham and I can say that we are longtime friends, but we are all too young to be too longtime friends. But nonetheless, we've broken bread over many sessions, and we have many common interests. And in addition to that, Cape Town is absolutely one of my favorite cities in the world. So I'm very excited that Graham has accepted the invitation to join this conference. And I really, really look forward to listening to the talk that he has put together with his team. And maybe I'll just finish by saying that if there's one lesson that we've learned from COVID, is that the world has to coexist together, and every single individual in the world matters. We're all really part of one large family, and all these divisions of borders and so on are really social constructs of the greatest order. So as physicians and as surgeons, we recognize the value of every individual. And I really commend you for dedicating yourself as well to this cause. And I can't wait for the conference to get started. Thank you so much.
Thank you so much, Dr. Hodai, for those encouraging words. I'm just going to introduce Dr. Graham Fieggen, who is our keynote speaker. Dr. Graham Fieggen studied medicine at the University of Cape Town, UCT, following which he obtained a Master of Science in Neuroscience from the University of London. He has spent 2 years as a general practitioner in rural Manitoba, Canada, before returning to Cape Town to specialize in neurosurgery, qualifying as a fellow of the College of Neurosurgeons and earning the doctoral degree in neurosurgery for work on a novel stereotactic device. He was mentored in pediatric neurosurgery by Jonathan Peter and worked as a consultant at Red Cross War Memorial Children's Hospital before being appointed as the Helen and Maurice Marburger Chair and Head of the Division of Neurosurgery in 2008. He is inaugural director of the UCT Neuroscience Institute and currently serves as head of the Department of Surgery at the University of Cape Town, where he supported the establishment of a new division of global surgery in 2019. Dr. Fieggen's clinical and research interests span functional and pediatric neurosurgery, and he was honored to serve the International Society for Pediatric Neurosurgery as president in 2018. collaboration with neurosurgeons across Africa led to formation of the Continental Association of African Neurosurgical Societies in 2014, of which he was the inaugural president, and he serves on the Administration Council of the World Federation of Neurosurgical Societies as president of the 18th World Congress of Neurosurgery, which will be held in Cape Town in 2023. Dr. Fieggen is married to Karen, a medical geneticist, and they are proud parents of Joshua and Liam, both alumni of UCT. Dr. Fieggen will be joined today by three amazing medical trainees in South Africa, Danielle, Robin, and Isma, who will be introducing themselves in more details later on. And we are very grateful to have them here. But before I hand it off to Dr. Fieggen, I know we are all familiar with Zoom. We've been doing it for the past, God knows how many months. But in order to just take your attention to the raise button function. So at the bottom, you can see the reaction, and then there is a raise a hand function. So if you would like to chime in the conversation, we would just ask you to raise your hand and we will unmute you to do so. Without further ado, welcome, Dr. Fieggen.
Right. Well, thank you very much. I really appreciate that very warm introduction, and thank you to you and Grace and the committee for the invitation. And a special thank you to Moji. It's lovely to see you online, and looking forward to getting you back to Cape Town again sometime soon. It's a real thrill to be part of this, and I really appreciate you allowing me to include Daniel, who's one of our residents or registrars, as we call them, in Cape Town in general surgery. And as well as Isma and Robin, who you're going to hear from just now. They're both finally medical students, and I thought, given it's a student conference, it'd be really nice to get student input from this side. So this is really a fantastic theme for a global surgery meeting, and I was asked to give a particular perspective from South Africa. So I've kind of subtitled it "A View from the South." It's a special thrill to be part of a meeting at the University of Toronto. As a neurosurgeon, I think there's little doubt that the University of Toronto is the leading neurosurgical department in the world. And as a pediatric neurosurgeon who's sort of gone the route of becoming a chair of neurosurgery and head of the department of surgery, I have to also confess that Dr. Rutger has really been my role model, and I don't think you could find a finer role model certainly in the world of surgery. So I think you're extremely fortunate to be at that incredible institution. So I'm going to give a little bit of an overview of COVID-19 and its impact in South Africa and impact on surgery, and just say a few words about global surgery, which is kind of very much a personal view on why I thought global surgery was important. And we have this really fantastic global surgery division that has thrived at UCT under the leadership of Professor Salome Maswimi, who may actually be online and may be able to comment a bit later. Then Daniel's going to talk about the impact of COVID on surgical trainees, and Isma and Robin will give you a few insights from medical students. Just to acknowledge one of your colleagues there in sick kids. George Azzi is a pediatric surgeon who comes to Southern Africa on a regular basis. And George really was the first person in the early, sort of around about 2010, 2011, who really started me thinking about the role of UCT as an institution in global surgery. But as our board said, my own Canadian links go back a bit further to small town general practice in Emerson, Manitoba, sort of right on the American border. It's the only time I've ever been on the front page of the newspaper. 30 years ago, I'm sorry to confess, Moji, but 30 years ago when I qualified for medical school, was a newly qualified little doctor and sort of went off to do my couple of years of rural general practice in Canada. And it was an amazing experience, I have to say, working in the Canadian healthcare system. I'm sure it's just as fantastic as it was then. I don't think there's any country in the world that has the same kind of equity of access to healthcare as you have in Canada. But it was apparent even then, 30 years ago, that there were inequities in the in society, and no country is perfect, and all countries have historical legacies that need to be dealt with. But I must say, I really, really enjoyed my time in Canada, and as that newspaper article says, it was sort of docs from Africa, and I think certainly from a global surgery point of view, that is one of the issues we need to confront with that. Many countries that produce healthcare workers, not just doctors, but nurses, lose them to other more developed countries. I came back to South Africa because things were changing politically here, and it was really exciting to be part of the new South Africa as it was then. But I must say, I still have extremely fond memories of Canada and the wonderful healthcare system we have and the amazing people in Canada. So this is kind of why we're meeting today. You're all familiar with these figures. This is from the Johns Hopkins dashboard this morning. Tragically, over 5 million people worldwide that have succumbed from COVID. South Africa, we've had nearly 90,000 deaths from COVID. We started a little bit later than you in terms of vaccinating our population. But as you can see, we're in the Western Cape, which is a part of South Africa where I live, we're close to 50% of the population vaccinated now, which we're hoping is going to protect us from the almost inevitable fourth wave. As you can see, we've already been through 3 waves of COVID there. So when COVID hit in March last year, our country actually responded incredibly quickly and very decisively. Like most countries, we had a lockdown imposed very quickly. One of the most important factors that had to be controlled was alcohol consumption because of the interplay between alcohol and trauma, and with the sort of very strict alcohol regulations that were brought in, we saw an immediate almost abolition of trauma, which was really quite salutary. Unfortunately, people can't live without alcohol for long, and it certainly had a huge economic impact. And as soon as alcohol became more freely available, the trauma numbers started picking up again. And that was one of the real challenges from a surgical point of view, was sort of managing trauma patients in the context of resources being diverted to manage patients with COVID. Oops, I seem to have a frozen screen. So as this cartoon summarizes, so Nelson Mandela, as you remember, was our first democratic president. One of his many famous quotes was, "After climbing a great hill, one only finds that there are many more hills to climb." And having climbed the hill of the first wave of COVID, we found that there's certainly been a few more hills to climb since then. So what has COVID done to us as doctors? Well, clearly, and this happened all over the world, there's been a massive reorientation of clinical services and a dramatic reduction in operating theatre time. We've lost 1,500 full days of operating at our main teaching hospital, Groote, which translates to nearly 5,000 operations that didn't get done. The kinds of operations that didn't get done were obviously in the main, the elective surgery disciplines like ophthalmology, plastic surgery really took a bit of a pounding with the reduced operating time. And a very important part of the discourse now, as we start to navigate our way back to a more normal situation, is setting priorities and determining kind of where we're going to now put resources in terms of trying to recover from that. And one of the other interesting things that you don't have in Canada is we have a dichotomy between the public sector and the private sector. And one of the, I guess one of the upsides of COVID was bringing a greater degree of collaboration between the private sector and the public sector, recognizing, as Moji said, that actually this is a condition that really forces us all to work together within countries and between countries. So surgeons had to deal with a bunch of new and unusual tasks. We generally think that infectious diseases is something that the physicians and pediatricians treat, but we all had to muck in and get involved in dealing with the clinical services and providing care for patients with COVID in sometimes quite difficult circumstances. I want to just highlight the need to develop a surgical recovery plan, because I think that's really where the value of global surgery has been felt. So the impact on staff has been huge. We've had 3 different waves, 3 different models by which we've deployed staff to different areas of work. And there's no doubt we've had to pay a lot more attention to mental health. The kinds of services we've offered, emergency medicine is actually part of the Department of Surgery here. Our emergency medicine department ran the field hospital that accommodated nearly 1,500 patients at one point. Global surgery, you'll see that graphic in the top corner there. I got involved in finding ways of connecting people who didn't have data to get information about COVID. Orthopedic surgeons got involved in developing all sorts of interesting technology and even organized some sporting events, which is par for the course. Lots of predictions of what impact COVID would have on surgery. Obviously, if you're going to have a baby, then that is not going to be stopped by a pandemic. If you need cancer surgery, then clearly that also needs to go ahead. But if you're going to have surgery for a benign condition, then that's not going to happen with a pandemic. This is some modeling done by a group in the UK, published middle of last year. And the most startling part of this graph is if you see the number of operations done in South Asia and Sub-Saharan Africa, which represent at least a third of the world's population. And I think this one graph really graphically shows why global surgery is such an important force in modern medicine, that we really, really have to find a way to enable people living in those parts of the world to get access to surgery. We try to do some modeling in Africa and different neurosurgical services, trying to figure out the impact of COVID on neurosurgical training. As you can see, we got responses from nearly half the countries across Africa. In terms of the reality of what happened, this is what we had in our hospital. The top line is the baseline surgical workload in 2019. That's about 1,500 cases a month. You can see in 2020, when COVID really hit in April, May, our number of cases bottomed out at about a third of the normal number of cases. And obviously with each successive wave has been reduced significantly. One of the problems is that leads to a backlog of surgery. But one of the lessons we're starting to learn is that sometimes one can't just catch up that backlog. And I think one of the important lessons going forward is going to be finding ways to reduce the impact and not actually kind of build on this backlog, but actually find a way to keep services going through any future waves of COVID. So I'm not going to say too much at this point, because I've got people who know far more about the impact on their education and training, who are going to talk to you in a few minutes. But I think for me, the bottom line is that COVID really has been an opportunity to think a lot smarter about what we do in the education space and to innovate in some interesting and exciting ways. Just a couple of examples. Our ENT colleagues have really fantastic connectivity across Africa with lots of trainees that have gone off to other African countries. And they put together, which they've published recently, some really interesting and worthwhile kind of online kind of educational activities. We did a similar thing in neurosurgery, pulling together all the different departments in the country in these 2 weekly webinars. And there's a sense of unity within neurosurgery in the country, which is unprecedented. And you know, that things like that are really precious dividends on a difficult time. But of course, we can't live in this atomized world of doing everything by Zoom and Teams and that sort of thing. You really want to actually get your hands dirty as a surgical trainee. And that's really where labs come into their own. I just want to mention one interesting thing. You'll see there's a phaco lab in the top picture there. We're teaching ophthalmology trainees how to do cataract surgery. And there's some very interesting data presented at our research day last week, where posterior lens ruptures in cataract surgery is a good proxy for skills. And there was a significant increase in posterior lens ruptures over the last year by surgical trainees, which points to a significant loss of skills over the time of COVID. And that kind of robust data actually really sort of makes us focus on what we're going to do to correct the impact on training. So we have a number of labs, which is really valuable. And I think, you know, all over the world, we've discovered the importance of starting to teach surgical trainees basic skills in labs rather than operating theatre. And actually, in reality, that probably was a lesson that we were going to have to learn anyway. So I think that's one of the positive consequences of COVID, that it's really forced us to embrace the use of technology early in surgical training. So we have a traditional department of surgery, just like you have at, I think, pretty much every Canadian university, where all the different surgical disciplines are coalesced in one department. The real jewel at this point, as I said, is global surgery, which is a new discipline, but has really been an amazing revelation in terms of what it's had to offer. So if we look at this a little bit more closely, in 2015, when the Lancet Commission published their report on global surgery that really sort of got the field going, in South Africa, we were grappling with confronting some of the uglier aspects of our history, and particularly the notion of decolonization and dealing with the consequences of centuries of colonial impact in the country. And I think decolonization and global surgery are two concepts that need to be discussed in tandem. So global health, one could cynically say, perhaps in some people's eyes, is healthcare for other people's countries. I want to just be very clear that global health is not the same as international health, and it's important to make that distinction. For those who are interested, I'd encourage you to read this article in Lancet about a decade ago that pointed to the difference between international health and global health. And global health really is a dynamic discipline that really is very interdisciplinary and is focused on health equity in a way that international health is not. Global health clearly does have a downside, and I think it's really important to recognize that in many respects, global health has historically been led from the north, and most of the people who, in a sense, are the consumers of global health are in the global south. And it's important to have leadership, I think, in a field like this in the global south. So as I mentioned, we've been very, very privileged to have Professor Salome Maswimi, who's actually an obstetrician, who accepted a position as head of global surgery in our Department of Surgery here at UCT. Salome has come with a very powerful vision to develop global surgery as a vehicle for ensuring adequate access to comprehensive and quality surgical care across Africa. And COVID has really been an amazing opportunity to understand just how powerful this vision is. As I said, it's important when you talk about global surgery to recognize that global surgery is not just about delivery of surgical care, but it's about public health and perhaps as importantly, public policy, because without public policy, you don't actually have opportunities to implement the strategies that you have to deliver enhanced surgical care. So this is the conceptual framework for global surgery at UCT. And it's around four sort of major spheres of activity: research and education and advocacy, which you're going to find in the curricula of most global surgery programs. But I think the real sweet spot for global surgery programs in low and middle income countries is implementation, that we have opportunities on our doorstep to actually make this stuff real. And that's about ensuring that we really do take seriously the notion of health equity and deliver the kind of leadership that makes that possible. To find ways of implementing all the fine things we want to do in global surgery, and to ultimately to translate that into policy and into government kind of changes in the way governments do things in order to really change people's lives. So I want to end off with really sort of highlighting the fact that, in my view, kind of in a sense, global surgery has really given us the tools to deal with the COVID-19 pandemic in ways that we would never have done previously. And in a way, it's kind of been perfect timing, certainly in our institution. It's given us a way to understand how to put a framework in place to deal with the impact of COVID. It's the kind of systems thinking that global surgery brings, and the focus on equity and advocacy has been really important. And for me as departmental chair, I found it really valuable to have global surgery directly involved in all of our clinical meetings. It's not just been an academic activity where it's been about teaching and writing publications, but it's really been about kind of engaging with the day-to-day reality of retooling surgical services to deal with COVID. And actually, one of the coolest parts of the whole thing has been the way in which the Surgical Student Society has kind of embraced global surgery, and it's been a really powerful synergy. And just to end off with, I spent most of yesterday in this International Global Neurosurgery Education Summit, which has really been about trying to develop new kind of neurosurgical training tools for use around the world. So this is real. I mean, this is something that's actually in dynamic kind of development at the moment. So I really want to congratulate you on the theme that you've chosen for this meeting, because it's very, very timely. Okay, so just to end off with, I really like quoting from Archbishop Tutu, who's, I think one could say, everybody's favorite living South African. He espoused the philosophy of Ubuntu, which is African humanism, which is the notion that we're all defined by our relationships with other people. And I think that really, if we hang on to that as a fundamental sort of philosophy for global surgery, we're going to be on the right track. So I'm going to hand over to Daniel at this point, who's going to tell us a few things about the impact of COVID-19 on surgical registrar training. Thank you very much.
Hello. Can everyone hear me?
Yeah. Hi, Daniel. You're coming through loud and clear.
Okay. So I had some problem there unmuting. So my name is Daniel Nell. I am a PGY5 resident at the University of Cape Town. It's really an honor for me to be a part of this this conference. And thank you very much for the invitation, and congratulations for hosting such a wonderful event. Just a quote from the father of our Rainbow Nation: seeing as education is really my passion and my interest. And he said it's the most powerful weapon by which we can use to change the world. And I think that's something that's very pertinent to COVID and what it's done to our training platforms. In terms of the impact of COVID on residents at the University of Cape Town, we've been forced to work in COVID ICU, in the COVID wards, as well as in the admissions units, as the physicians were completely overwhelmed by the pandemic. We've had a lot of elective clinics cancelled, far fewer surgical inpatients. As Prof. Fieggen said, we've lost about 1,500 lists and almost 5,000 patients that get operated on. And because of restrictions on group gatherings, we've had to move to online lectures. And this is a study that we published a few months ago in Surgical Innovations. And what we did is we asked all of our residents to give their opinion on the new online teaching platform. And you can see 86% said that it was an adequate substitute for teaching during the pandemic. And quite interesting, 68% said that online teaching was actually superior to traditional in-person teaching. Majority of residents said they're more likely to attend when they're at a satellite training hospital, when they are post-call. They can listen to the lectures again. The chat function is very helpful and allows exposure to experts from the private sector. So really improving accessibility to academic teaching. However, 54% of residents felt that teaching on operative technical skill was not being met. And to put another way, only 16% felt that it was. 92% felt that virtual simulation technology should be explored to cover the gap in operative exposure. And 90% said video-based teaching should also be explored. So this study concluded that while online lectures were an adequate replacement for traditional lectures, clearly the need for operative training wasn't being met for residents, and that the growing deficit in surgical skills training needs to be addressed as a matter of urgency. This is another study that Prof. Fieggen also highlighted, which just showed the devastating impact of COVID on our local hospitals. So this study compared a 3-month period in 2019, pre-pandemic, to the same period in 2020. And they found that in total, general surgical operations decreased by 44%, elective cases down by 74%, lab choles, which is one of our bread and butter surgeries, down by 68%, and trauma also down by 42% with the alcohol bans, like Prof mentioned. I firmly believe that we are heading for a skills crisis in general surgery. We're doing far fewer lab choles as residents, especially the easier cases, patients 1 or 2 biliary colic. We're doing patients with severe gallstone pancreatitis or choledocholitis. We're doing fewer elective hernias, especially laparoscopic hernias, which are now preferred and expected by patients, especially in the private sector. We're missing many scope opportunities, especially colonoscopy. Many of those were cancelled in the pandemic. We're treating conditions like appendicitis conservatively with more enthusiasm, which provides less opportunities to practice basic laparoscopic skill. Like mentioned, we're also having far fewer trauma laparotomies with the alcohol bans, and time that you have to take off when you are sick or your childcare is sick or your relative is sick. A simple cold is no longer just a cold. It could be COVID. So I think we're unlikely to reach the numbers, adequate numbers that we need by graduation, especially if the resident joins a program with little experience. At this stage, our final exams are only assessing theoretical knowledge. There's no actual assessment of practical ability. So I think increasingly we're at risk of graduating surgeons that are not competent and unsafe, exposing patients to surgical errors and the doctor's health system to medical legal risk. We may ask, will things go back to normal? This is a survey done by Nature where they asked almost 120 immunologists, infectious diseases, and other smart people, personally, how likely do you think it is that SARS will become endemic? And 60% said very likely, 29% said likely. And then how likely do you think it is that SARS can be eliminated from some regions, with the majority of brainy people saying it's going to be unlikely? So COVID's here to stay. So what can be done? Well, clearly we need to maximize resident exposure during the recovery phases as we go through the waves and we recover. However, there's going to be a greater push for efficiency and speed in theatre because of the massive backlog. So like Prof. Fieggen again said, our residents have to be well prepared. We can't be training soldiers in the heat of battle. They have to be ready when they get to theatre. There's going to be little opportunity to learn the basics there, and we have to rethink the way we train surgeons and assess them. So a number of innovative tools that can be used. Residents have always been using platforms like YouTube to look at operations, but YouTube is quite limited. It's not standardized. It's very hit and miss. There are new tools available like Incision Academy, which is a wonderful tool accredited by the Royal College of Surgeons in England, with kind of standard curricula that residents can work through. There's also wet lab workshops that one can run more aggressively for open surgery, laparoscopic surgery, and endoscopy. Simulation is another area that's really very useful to be used in this area, like using box trainers for not just laparoscopy, but also endoscopy, as well as virtual reality simulators for laparoscopic surgery, as well as endoscopic procedures. And the different ways in which we can use these kind of things, like box trainers, for example. On the left, you can see kind of a very fancy one with a built-in camera and computer system. And then you got the kind of more LMIC option where you can put your tablet over a little hole using that as both the screen and the camera, and you simply have to buy a box and instruments. You can have a fancy EndoSim platform which costs $130,000, or you can use a more cost-effective box simulator. There's the flagship kind of haptic laparoscopic simulator devices, or you can use kind of more low-cost options with a laptop instead of the fancy screens. So there are ways in which we can make some of these technologies a bit more accessible to LMICs. There is evidence that simulation helps. A review by Sages in 2016 showed that for lap colis, residents operated 30% faster, were 5 times less likely to cause injury to the gallbladder or other structures. The operations went faster, therefore they were cheaper, and increased theatre productivity, which is something that's going to be very valuable as we try and recover from the COVID pandemic. Just to show, I know many of you are medical students, kind of where we're heading, and I don't know if Toronto has this technology available already. That'd be really, really cool, but kind of towards fully immersive virtual reality, where you put on a headset and you can actually be in theatre doing the operation, hearing the theatre sounds. You can look to your left and see the scrub nurse, look to your right and see the anaesthetist playing Sudoku. And this, even a further step, is kind of a more realistic picture when operation is recorded, pre-recorded, and the screen is superimposed onto where the lap stack would be. So very exciting how we can create these immersive simulation experiences, and I think the technology is fast approaching. However, these solutions do cost money. Open or laparoscopic workshops for us for about 12 to 16 residents cost about $2,000. The Incision Academy platform that I mentioned for e-learning is about $8,500 for our 50 residents, and that's at a very generous discount from the company for developing nation and for a bulk order. The basic lap, entry-level lap Essence system is $30,000, the Endosim $130,000, and the lap haptic, the kind of flagship device, $200,000. It's not all of these are affordable in LMICs. So in terms of what strategies we can adopt for resident training post-COVID, I think we have to recognize that every resident has got a different background and proficiency, especially in our setting, where you have residents coming from international countries fresh out of med school, or you've got residents that have spent 4 or 5 years already in a surgical environment operating independently. I think an individualized approach is key to assess for individual strengths and gaps and to design tailored strategies to address these gaps very early on. And then, of course, to follow up to make sure that goals are met and maintained. Versus our old approach of residents just going through the rotations, colorectal, endocrine, vascular, and then trusting that skills are acquired by them just seeing enough cases and putting them in their logbook. And it's critical also to know that for simulation, learning, feedback, and debriefing is key. So we need faculty surgeons to monitor what's going on and to provide feedback. The simulation room can't just be a games room for residents to play around with. So how can we assess individual skill strengths and gaps? Well, we can look at a number of key procedures, but I think more valuable looking at self-rated competencies. There's a number of scores that can be used for this, or a number of tools. The one I prefer is the Ottawa surgical competency for the OR evaluation, which is a measure of entrustability rather than just a rating score. So you can see this is looking first at numbers of procedures. This is a survey I sent out to some of our new recruits in the department. There you can see there's one resident has done 10 amputations and one who claims to have done almost 500. I don't know where they were working, diabetic hotspot or something, but you can see that person should be capable to perform an amputation independently. But this is the Ottawa score, which I think is actually extremely valuable in kind of self-assessment and also then objective assessment by faculty. You can see 2 residents at the bottom blue part of the pie chart said, I need complete hands-on guidance to perform a laparoscopic cholecystectomy. And you can see at the top, the one resident says, I can do parts of it, but I constantly need to be told what to do next. And kind of higher on the scale, one resident says, I can do the whole procedure, but I still need a senior in the room just to be safe. So using these kinds of tools, you can tailor your training programs. You don't put everyone through the lap simulation course. You put only those that truly need to master these skills. We also have to rethink assessment. Seeing as our ability to train technically competent surgeons is at risk, we need a paradigm shift away from logbooks of cases seen and cases done, and a final theory-only exam to continuous workplace-based assessment of competence. This will allow us to identify gaps early and remediate them. And we also, and in education generally, we're moving away from rating and scoring systems to entrustability skills for residents to independently perform tasks. A fantastic example, again, is the O-score. In LMICs, these tools and these assessment programs need to be low cost. We can't always afford very fancy software for this. So a pilot that we are currently running at UCT is we've designed 2 Google-based forms. One is after intake ward round, the resident will fill out a few details and give their smartphone to the consultant or the attending, as you guys call them, to fill out a quick rating on their performance during the round, how they can assess and diagnose patients, use investigations and interpret them well, and make a sound and execute management plan. As I said, it's all resident smartphone driven. Everyone's got their cell phone on them all the time these days. It takes very, very fast to complete. It's not a big administrative burden. And if we just do 6 of these per rotation, we'll end up having almost 100 data points throughout the resident's training period. It also provides instant feedback to the resident and the attending. We've set it such that as soon as they fill it out, it immediately sends an email to the resident about their performance and to the attending and the HODs. Everyone can know where everyone is. And these can be reviewed periodically to remediate gaps. That doesn't cost anything. So to conclude, COVID has reduced and it will continue to reduce operative exposure for residents. There is a looming skills crisis, but I strongly feel it can be averted with intentional thinking and planning. There are many innovative teaching tools which can be employed. In LMICs, it's not as easy to apply as in high-income countries because of cost. There's also less pre-existing capacity. We don't have a sim lab where we can simply buy another 2 or 3 simulators. We need to build many of those things from the ground. And because of the clinical burden, it's difficult to ring-fence training time for residents and to provide individual consultant attention. But it's not impossible. You just have to be smart and work harder to get what you need. I think involving the private sector and industry is key. And it's important to network and to share ideas and resources between departments, divisions, universities, and internationally, which is, I guess, a platform like you've created today. We need firm commitment from academic institutions to invest both human and financial resources into training. I'd like to end off with this quote by Einstein that even though we find ourselves in a time of great difficulty, we must also realize this is a time of great opportunity. Thanks for your attention.
Thank you so much, Daniel, on that information. It was actually great insights to know how you guys are learning at a registrar level and how I think COVID has impacted. We would just like to thank you guys for this opportunity. It's so great to share this platform with other medical students and specialists in your field on the other side of the world. I just want to give a brief overview about our program before we actually discuss our surgical experience. So we do the MBCHB program here at UCT, MBCHB being Bachelor of Medicine and Bachelor of Surgery. It's a 6-year program. And so we spend first year to third year work focusing on theory, basic science, as well as becoming a doctor, which is just a program that focuses on interviewing and the humanity aspect of medicine. And then fourth year is when we begin our clinical rotations. In fourth year, we do kind of the core specialties, so internal medicine, peds, psychiatry, and public health, I believe, as well as emergency. And then fifth year is where we get our first exposure to surgery. And so Isma and I were actually in fifth year when the pandemic began. And in South Africa, the lockdown that we had was nationwide. It was like only essential services. So in March, our academics halted, which made a huge impact because we start our academics in January. So we were kind of in school for about a month, only did 1 rotation, and then the whole nation went on a lockdown. And so for 4 months, we were at home doing theory. And so we went through all of our rotations online, and we returned to the clinical platform in August when we started our practical aspects of the rotations. And so fifth year kind of takes a break from the core specialties and focuses on the subspecialties. So neuro, gynae, ophthalm, ENT, rheumatology, what am I trying to say? Urology. And because of the pandemic, we kind of rushed through those in the 4 months. And so when we started surgery, kind of towards the end of the year, it was a very different way. You know, usually when you start a rotation, it's a mix of theory and practical, but we spent a lot of the hours on practical. And so they had to prioritize our learning objectives towards the practical because they needed to ensure that we were safe doctors when we graduated. And then in 6th year is when you continue general surgery. And luckily there was no waves during that time. And so when we did general surgery, we were able to actually combine the theory and the practical and experience the rotation like as it was designed. But our curriculum definitely changed and things were prioritized and it was redesigned because of the pandemic and the subsequent lockdown.
And I think a big lesson that we learned from that is that a lot of work went into the preparation phase. So the 4 months while we were doing online, our educators were busy like re-evaluating what the curriculum looks like. So when we got back, it was already redesigned for us to start working on the clinical platform. So a lot of it went into preparation and in the rethinking and the reimagining phase so that when they had to recreate it, it made sense. And I think that's one of the lessons that COVID has taught us is we need to be prepared before crisis. so that when we're in the crisis, we're not like fumbling or trying to create solutions.
And I think, as Daniel mentioned, during that time, a lot of elective surgeries were canceled at the time. So some of those surgeries that we sit in and we scrub in, we actually did not have the opportunity. And so most of the time we would scrub into emergency surgeries. So it was a bit of a shock to the system, I'll say. Yeah.
Yeah. I think another lesson that we learned during COVID is the importance of the student role in a pandemic or just in a health system. We saw a lot of student societies coming up to the plate, not just in terms of community outreach, but in terms of curriculum and allowing other students to continue learning on the online platform. Some of the examples, I was in the UCT Surgical Society and part of the career development team, and we had a competition that students could do at home on surgical skills. So finding anything at home to basically suture and to improvise. And there were a lot of themes that came out. A lot of students picked up on the importance of sterility and vital signs. And we used social media to get people hyped up, and we had prizes. So basically having this concept of a traveling classroom where learning doesn't have to be in a building or in a specific place, but that learning continues outside of learning institutions. And Robin was a part of a lot of Shoko initiatives that also helped with surgical skills and training.
So Shoko is a community outreach organization that's student-led nonprofit. And during the pandemic, along with providing sanitation and health education to the communities that we serve, we also gave flu vaccines. At the time, there was no vaccine, but for the elderly, it was noted that flu vaccine would be an extra layer of protection for them during the pandemic. And so we went to the elderly in the communities, and that was also just an opportunity for students to get a chance for intramuscular and injections and giving vaccines and things like that. So we, just as Prof said, we had to adapt as well with kind of the programs and initiatives that we do as students.
And we had to start thinking the way global surgery allows us to, in that increasing access to communities that need it the most. And students played a big role in that. And it was a great opportunity for us to also explore global surgery. We had global surgery webinars. We had the opportunity to join the global surgery research team. So a lot of us got into research and the importance of global surgery in the South, because we see a lot of it in the North. So it was great for us to be hands-on in global surgery and explore different parts of our curriculum. So although COVID was a crisis, there's a lot of positive things that we learned from it as well.
Innovation, yeah. Someone raised a hand. I don't know if we're supposed to answer that.
Thank you so much, guys, for sharing all of your experience with us, from Dr. Fieggen to Daniel and to you. So we heard 3 different layers of challenges, but I think we all have also felt during COVID. Many of us are medical trainees, and I can tell that we hear you and we feel you, because our trainings was in not similar, but in very, I would say, aspects of it was affected like you guys. I think Dr. Kusimano has a question for you, and I'm going to ask him to unmute and ask the question.
Thank you very much. It was very interesting to hear the similarities and differences from South Africa to Canada. How long were you as medical students removed from the clinical sites?
It was about 4 months.
4 months in the 2 years. 4 months in the 2 years?
It was in the 1 year. So last year, 4 months. However, there were some volunteer opportunities. So Isma and I volunteered at one of the district hospitals here in Cape Town to help with the cesarean load. So at the time, a lot of interns and doctors got COVID, and so were unable to do their obstetrics block. So we volunteered in helping with assisting with cesareans, as well as, I think Prof mentioned the field hospital that was built in response to the pandemic. I volunteered there as well, and that was more secondary level. So helping patients on oxygen, high flow, and caring for them there. It wasn't really surgical, but it was still the clinical platform.
And so that's, you were able to volunteer unofficially from your medical school. Did you get credit from your medical school for that as a clinical rotation, or was it totally on your own, sort of something you would do on a weekend?
Yeah, that's as we volunteer quite a bit.
Yeah, you know, I mean, it says a lot about, I'm sure this is the way it worked across the whole world, is that the medical schools, and I suspect, although I don't know, I suspect it's related to liability. And the medical schools don't want to take on liability for the medical students. And it happened in Toronto as well. The medical students, you guys are all junior medical students, but from the senior medical students I've had, they were basically out of the hospital from March until the following August. Even though the youngest people, in other words, you 20-year-olds, are the lower risk category of people to get COVID, they kept all of us guys who are old folks operating, and yet they kicked out all the young folks from the institution. So it looks as like the same thing happened there. But if you want to volunteer, I'll keep my eyes shut and you can go ahead and do it. That's how it worked in South Africa. Is that right? At least at the University of Cape Town.
I mean, the work that we were doing as volunteers is the work that we were allowed to do in our medical curriculum.
Yeah, but then the medical school didn't condone that. Something you had to go and search out on your own.
No, it did. Yeah, it was. I mean, you're quite right. I mean, there was concern about. Well, I mean, I guess we're in a far lower sort of medical legal kind of risky environment. There's much less litigation here in North America. So I guess.
But still they did the same thing though.
Yeah, I mean, the main concern was concerns around students being put into a potentially hazardous situation where one couldn't really quantify the risk. Although, as you say, for young students, you know, in their 20s, the risk had to be very, very small. I think it was only about 4 months that you were completely out of the clinical environment. And this year, all your rotations pretty much have continued as normal.
Yeah, that's good. I'm not saying anything good or bad. I'm just commenting about what happened to our medical students during the COVID. Dr. Hade may have some comments. She has her hand up.
Yeah.
Well, my comments were a bit different. I wanted to ask particularly the medical students about vaccinations in South Africa, whether there was an opportunity or there were any specific ways in which medical students were vaccinated sooner than the regular population. And did you have any opportunities to help vaccination campaigns in South Africa?
Yes, that's a very good question. So yes, medical students, well, healthcare workers were given the opportunity to vaccinate earlier than everyone else. The beginning of this year, we got the Johnson & Johnson. And there's a vaccination site that was opened up by our university called the UCT Community of Hope Vaccination. And as part of our curriculum, you, as a medical student, have to do not a rotation, but a session in one of those vaccinations. So you have to vaccinate at least 3 people and register at least 3 people in the system. So that's been our exposure. And currently in our family medicine rotation, we do a lot of vaccination counseling. So all our patients in primary healthcare are encouraged to vaccinate, and those sites, our clinic sites, also vaccinate. So we get to do it at the same time.
And then I think in terms of, like, just to add on, is that the societies were also involved in health promotion towards vaccination. We weren't part of the societies this year. So last year, the health promotion that we did was more towards sanitization, wearing masks, and the safety and precautions for COVID. But this year, I know on social media and in the outreach communities that we work in, there was a lot of advocacy and like importance and highlighting the importance of vaccination. And when the Johnson & Johnson was distributed here at GSH, it was kind of equal opportunity. So you'll have like an HOD standing in line with the students, standing in line with the registrar. Everyone was allowed to sign up and got equal opportunity to the Johnson & Johnson. And that was discussed thoroughly before at the faculty, where students were advocating and not necessarily fighting, it was just a discussion to just ensure that we were part of the first rollout of the vaccine.
And I think Carl raised a very good point that probably Canada had a little bit more restrictions on medical students than what we are hearing from you. And I think my fellow medical trainees can attest to that. We did not have those opportunities that you did, which is very very interesting to hear about these differences. I'm going to hand it to Yusuf. He has a question.
Hi guys, my name is Yusuf. I'm a fourth year medical student. I just had a quick question related to your role in the COVID pandemic. I know you mentioned you were involved in some of the vaccinations. Did you have any responsibilities outside of that? And I just say because I know it could be really frustrating as a medical student. You want to help out, but I get it. Your capacity is a little bit limited compared to the residents and attendings. But outside of vaccination, did you have any responsibilities?
Yes, we had academic responsibilities, as well as the hotline. So when it was declared a disaster in our country, there was a disaster COVID hotline, and basically the students were manning that. So we did 12-hour shifts at the hotline, answering questions from the public, redirecting like the ambulance, making sure people did have COVID symptoms and where they had to go get tested. And we got an opportunity to work with very different people in the health sector, from the head of like people doing ambulance work and emergency services, to nurses, to the head of public health. So yeah, that's our experience. And we got some experience in the labor wards as well. And just health promotion and education on social media. I think a lot of people were anxious at the time, and anyone who was in healthcare was basically approached. So our role passively was to also do some health promotion.
And then I think also in terms of COVID obligations, if that you might have been referring to that, in our rotations, we're not obligated to see COVID patients. Because we don't have any occupational insurance. So if we get sick, we miss our rotations and we have to repeat the year. So it was understood widely in the student population that we were not forced to see COVID patients. We did see COVID patients, Isma and I, just to help out our medical team, because when you're intaking 40 patients and 30 of them are COVID and you want to go home at the end of the call, you want to help everyone out. But there was no obligation. We were never forced to see COVID patients. Even during our surgical rotation, when a patient is being intubated, even though they tested negative before their operation, we still stood outside and waited for the intubation to be complete, because it's an aerosolizing procedure. So it was never mandatory for us. Yeah.
So much. And I think Dr. Kusuman has a question, and probably after that we would try to wrap up the conversation so we would have enough time for our morning workshops. Dr. Kusuman?
It's really just a comment that the lack of clinical experience, as Professor Fieggen mentioned, is a big deal. And it's not just from the medical students, not just from the residents, but also from the program directors trying to determine which students to let into programs. Now, the last 2 years have been diminished in terms of students going through their last couple of years of rotations. You're lucky in South Africa, you were allowed to come back into the general hospitals, but we in Canada, at least in Toronto, are having students that haven't really been in the hospital for the last 2 years, and we're trying to determine who to let into our programs. A difficult decision. It is truly a very difficult decision for us to determine, especially in the smaller programs, who to let in. And it's going to become very, very difficult for us to try to figure out levels of competency of people coming into programs. So it's a very, very difficult situation, and it goes throughout the whole world and in all levels of medical education, including trying to get people into residency. So it's a problem we all have to contend with.
So maybe, Dr. Kusumana, maybe I can just comment there. So we had an unusual meeting yesterday morning where the entire clinical leadership of the hospital got together with hospital management. In all the years I've worked here, we've never had a meeting on that scale. And the overwhelming consensus was that of all the problems we need to pay attention to, really being absolutely intentional about getting registrar training or residency training up and running was just mandatory, because if you're not doing that, the impact on multiple generations is huge. I think we all knew that this was going to be a problem, but I think none of us really fully appreciated the scale of it. And I think that very strong awareness that this is now an emergency. We've really got to make a plan to get clinical, and the simulation, all the stuff that Daniel described is incredibly important. And I do think that in important and meaningful ways, we can end up in a situation where we offer better training in a few years' time. Because I think we certainly, a lot of us, I think, didn't really pay as much attention as we should have to simulation and all the other training options that were out there, but just seemed a lot less interesting than actually teaching people kind of, in the clinical environment. But I think once we get clinical activity back up and running with all these other things, we'll be in a better place. But there's a big gulf that's got to be bridged at the moment. And as I say, I think here there's almost a sense of it being an emergency that we really got to get back with very quickly.
Yeah, I tend to agree with that very strongly. We've even in cardiac surgery, I don't know about the other specialties in Canada, we've changed the way we examine our residents at their fellowship exams as well.
Yeah.
So, it's a big problem around the world.
So cardiac surgery is interesting here, and the pediatric cardiac surgery kind of, well, and certainly most of neurosurgery continued. 80% of our neurosurgery workload is emergencies. Very little elective work anyway at the best of times. So discipline in pediatric cardiac surgery, you'd know better than I do, but most kids who need cardiac surgery absolutely cannot be postponed. But adult cardiac surgery really took a pounding. Big deficits there in operative experience.
As much as I enjoy hearing the conversation, I think we need to give everyone a little bit of break before the morning sessions. Thank you so much, Dr. Fieggen, Robin, Esma, and Danielle for this very thoughtful conversation that we had.